Hello, everybody. My name is Samantha Gelman, and I'm an internal medicine resident at Riverside Community Hospital, UCR School of Medicine. Today, I'll be talking about a case, SARS-CoV-2 myocarditis. A COVID heart is a sad heart. SARS-CoV-2 myocarditis is a known complication of the virus. Current data shows that up to 7% of COVID-19 related deaths were attributable to myocarditis. However, this percentage may be considerably higher than anticipated, as cardiac complications were initially overlooked and there was question about the existence of COVID myocarditis. With myocarditis cases emerging, we note variable presentations from mild symptoms to heart failure and cardiogenic shock. However, hemophagocytic lymphohistiocytosis, otherwise known as HLH, in association with SARS-CoV-2 myocarditis, is particularly underdiagnosed, and here we present this atypical case. A 42-year-old male with past medical history of diabetes presented to the ED with symptoms of shortness of breath associated with cough, dyspnea, and diffuse myalgia. He was found to be tachypnic with sinus tachycardia, in DKA, and positive COVID testing. Labs were remarkable for elevated inflammatory markers with hyponatremia at 122, hyperbilirubinemia with a bilirubin level of 6.1, hyperglycemia with a glucose of 523, transaminitis with AST of 4,779 and an ALT of 725, and lactic acidosis with a lactic acid level of 6.1. Chest x-ray, as noted by Figure A, revealed an extensive multilobar pneumonia with prominence in the right mid to lower lung zones. The patient's respiratory distress continued to worsen, leading to intubation due to presumed ARDS while he was still in the ED. The clinical course was complicated by echocardiographic findings, as noted in Figure B, of a hypokinetic left ventricle without a collapsed IVC or evidence of pericardial effusion. As you can see here, we can appreciate an EF of 10 to 15%. Further testing was conducted, and it was determined that the patient had an elevated H score of 162, corresponding with a 40 to 50% chance of HLH. Blood cultures were negative, while urine cultures were positive for Candida. Chest CT, as seen in Figure C, was consistent with multilobar pneumonia with a right pleural effusion and mediastinal emphysema without evidence of pneumomediastinum. A CTA of the coronaries was also conducted, but was unremarkable. The patient was started on a beta blocker, ACE inhibitor, a steroid with taper, and acyclovir. His clinical course began to improve with this treatment, and repeat echocardiogram was done in Figure D. As you can see here, the EF has improved to 45 to 50%. The patient was discharged with close follow-up and the aforementioned medications. This atypical case displays a patient who was young, without any cardiac history, who developed SARS-CoV-2 myocarditis and secondary HLH. This patient's rapid deterioration of cardiac function with subsequent improvement post-treatment points towards the diagnosis of COVID-19 associated myocarditis. HLH may overlap with the symptoms of severe COVID-19 infection or may be secondary to an immunocompromised status. By testing for interleukin-2 and NK levels, you can assist in making the appropriate diagnosis. Severe cases of COVID-19 overlap with HLH and may even be confounded by secondary HLH. Furthermore, a COVID-19 infection may present as new-onset myocarditis that improves with time if treated promptly. In this case, these conditions occurred as a consequence of one another and should be considered even in younger populations. Early recognition and management is crucial in the overall prognosis of these patients. Thank you for allowing me to present, and have a great day.